Merhabalar.
Hello, welcome to this very nice symposium. There's a very nice weather outside. I hope you will be happy for being here. We have very prominent speakers. And the name of our symposium is different perspectives in psychiatric disorders. So we have three speakers, star speakers. And Professor Feyzi will be the co-chair. The first speaker is Saffet, Professor Saffet. He is a star. 10 years ago, we said the star is to be rise, but now the star has risen and then made this continue. In of neuroimaging, he's studying neuroimaging. He has very good publications. Although there are some grand problems, he is diligently continuing his works and studies, and it's not always possible to get grants. If in neuroimaging, if there isn't an understanding, there's no money given. This subject of this neuroimaging, actually, Saffet is going to talk about functional and structural brain changes in high risk women for depression. Functional and structural brain changes in high risk women for depression. We're excited to hear that presentation, sir. Thank you. I don't know whether we have risen or not. I know where, which part of us has risen. So actually, I'll talk about a study which has started to yield its results, and ongoing for 10 years. This study has been ongoing for long years, and what we are focused on is depression. Why? Because it is quite common. So when we know that in the last 1 year, 6.7% of the population has experienced depression once at least. It says once at least, and we know that the episodes are quite long. The episodic course is something we don't see, unfortunately. Almost 10% of the patients have a disability, and in 2020 that will be the second most common cause of disability, and there are direct and indirect causes. In repetitive depression, they have shorter life experience of 5 years. When we consider this from a different angle, the risk factors, if there's a family depression in a person, since the babyhood, the infantness, there are problems. There are some depressive problems during pregnancy. This affects the infant, and there are negative family environment, childhood trauma, and early loss of parents, and with the genetic burden. This is a risk. This becomes a risk factor. The risk factors decreases in the long term. It turns into environmental risks, and there could be vascular risks, and also spousal risks are the risks in the late ages. We are more related to family, because if there's a depression in the family, there's chances, if there's a depression runs in the family, the risk of depression in the infants increase 2 to 4%, is fourfold. So it is more common in female children, not in male children. When the depression starts, especially before adolescence, prognosis is bad. There are the repetitive prognosis, and they give first responses to treatment. Yes, we want to treat this, but the thing is better to prevent rather than treat later. There are some treatments. We have CBT, interpersonal psychotherapy, and also there is, I don't know what, there is a third wave is CBT. When we have this in concrete review, there is 11 patients should be, at this 11 patients should be treated to be beneficial for one patient. This is a high number. In entire, the energy rate is 5 to 7%. And on the other hand, in antibiotics too, in CBT 8. So in terms of prevention, we are lagging behind in the treatment. When we make an intervention, we see lesser results in prevention. And can there be some other methods to prevent this? Because the psychotherapeutic methods are not, let's say, very effective. Of course, in order to come up with this method, we can see which hypotheses are valid among the working ones. What data we have? The HBA access is deteriorated, structural deficits, and emotional regulation problems. Regarding the emotional, there are emotional regulation problems, and there are many studies showing all these, and in all these publications and studies, the hypotheses are valid. Cortisol, actually, in the cortisol rates could be high, and especially in depression diagnosed patients prenatally, the cortisol level is determined at the age of 13 for 19 years of age. It's predicted if there is a depression in the mother, the cortisol rate actually it can be predictive for the late age. But this is a kind of a complicated data because mother's depression determines the 13 years of diagnosis, but even if this might seem predictive, it goes away in 16 years of age. So the effect decreases when with this start of adolescence. There are two important studies regarding cortisol. If we consider the cortisol, so morning cortisol and cellular control cortisol levels are higher. And the second is better study. The relatives are taken into account, and after 2 years, it is examined again. Geriatric stimulation. When geriatric is given, and cortisol is higher in the relatives. Actually, this was quite determining in our study schedule. In the relatives, even if the years page, even if you go control the HbA, there is a tendency of elevated cortisol. There are many studies in this regard, but this shows very well. We see 13 years of age when you consider hypocampuses. With the mother with depression, we see that they have hypocampuses are 6% smaller. And what happens in emotional dysregulation? When you see the video clip are observed by these children, the amygdala system is more active, and in medial-prefrontal cortex is activated as well. And when the other tests are run, when back induction is made, again medial-prefrontal cortex is more active. This is quite effective. Amygdala and prefrontal cortex, there is a balance for their working together. To what extent they're working together actually makes the people have better opinions regarding their future. This is not activation. This is a statistical analysis, amygdala and medial prefrontal cortex. If they're working coherently, people think more positive terms. However, when the coherence is started to deteriorate, the person becomes pessimistic about the future. The active amygdala and the fact that there's frontal context are not something that we don't expect. And these studies are conducted in risky groups, but the children, their age were before adolescence. I would like to remind you of this because with the adolescence, brain changes a lot. So what we think, we said that we have such data. We said let's test your hypothesis. HPA function, there's an HPA axis dysfunction, and it is the most valid information in the classical textbooks. We accept this one, and we accept that cortisol causes structural and functional alterations, and then we think that emotional regulation problems would occur in high-risk populations. So when I was giving this project to be talk, if there is HPA, this axis dysfunction, the other parts would be corrected. So what did we do? We selected women with familial depression, and they have to have daughters to 18 to 20 years of age daughters. Finding such a group is actually very difficult. They shouldn't have experienced any depression. The women have to be 30 to 45 years of age, and there should be 2 more people in the family with depression, and it was a very difficult group to find. And in 4.5 years we found this group, and they're healthy mothers. They have daughters. They shouldn't have any psychosis, etc. And the exclusion criteria was bipolar. We actually thought of SPEC, not fMRI. That's why the age was 18. And with SPEC, they cannot be administered with radioactive matters. After the evaluation of the patients, after in individual phase, evaluation was taken into effect. Functional MRIs were taken, the cortical thickness and oxy-base formometry was taken into account. There are 2 parameters. One is the linearity, and the other gives information about volumetry. And then there was fMRI. You will see what kind of a cortisol rhythm that we have, and we took blood, and after administering of dexamethasone, and we run the CRH test. The patients, they have the daughters between 18 to 24 years of age. We said a remission, but when we say remission, it is not possible to find familial depression. However, the patient should be depressive, but it should not affect their daily life. And the emotional dysfunction, the scale is applied. And in daughters, even though they didn't experience an depressive episode, their depression scores are very high, and we see that there's mild depression symptoms. Everything is very well structured in the project. Actually, Turkey gave the highest score. Actually, I will exceed my time a bit. Actually, the hypothesis is very good, and you're planning to run a test. But when we received the data for the first time, they were quite striking. The red one is the TCH in the mother. These are the rhythm in the daughters. CTH is lower than the control group, and it's significant, statistically significant in the mothers. morning cortisol levels are important, and actually some of them are in the afternoon or the evening time. Actually, in our patients, this very low. The start of hypothesis, actually, what I imagine to find a treatment is that actually the variations were not close to the higher level. Those was talking about some variations yesterday. Ours was very clear, very low range, and there is it shows a central HSP decreases, and there's adrenal decrease as well. So when we did this, we administered dexamethasone, and the cortisol also they were zeroed, and when we give CRH, the TSH were elevated, and they were elevated in other mothers, and it is very parallel with the daughters. Sometimes if the psychologists, if they I would say whether they take this, they will take this samples from the lab intentionally. There's an adrenal deficiency in the mothers and in the daughters. So this is confirmed the hypothesis. We needed to stop in the first step of our hypothesis. What happened in cortical and in temporal parietal area, there are volumetric decreases, and this decreases, it's in parallel with the decrease in cortex thickness, and in media prefrontal cortex and insula, bipolar thinning, and fusiform cortex is a standard almost in all in the old studies. There's a cortical thinning. Actually, our advantage is that they have the mother, so we see the pre and post depression. However, in temporal parietal around in orbitofrontal cortex, there wasn't any similarity with the daughters. It shows that when we're thinking schizophrenia, high risk, as it's in high risk, there are losses in the first area. So one area is going from one area to another. However, in high risk and mother brains, doesn't seem that there are the progressive changes. So these are like separate situations, and when they're in depression, the developments in the brain would seem to be different. And in hippocampal volume, there is a decrease. This is something we didn't expect. We expected that there would be. If the working hypothesis is cortisol, we actually here we see that the cortisol levels decrease way below that we expected, and instead of this, we actually checked hippocampus to see if there are other defects, and there was 3D shape analysis. It's a more sensitive analysis. This is the advantage of this. So there is a 1 to 2% of area, there is a shrinking narrowness in cornea amorphous area. This happens, and this is the equivalent of that area. The green area are the narrowing parts, and you see the red parts. So these are more to the exterior. In such a specific part, there is a narrowing. Of course, we do not know what that part means, but we see in the relationship with the limbic system, and hippocampus is important, and of course the temporal parietal fusiform hippocampus parts, what would be the parallelities, it led to that thinking. And there is also fMRI, and the fMRI task is the emotional regulation from IRMs. We show some pictures to people, and before they are in fMRI, they are trained. They have two options here. We tell the options to them during MRI. they see the image and they continue to experience the same feeling or change that feeling. What kind of a change they make? This scene might not be a real person committing a suicide, or the person can, instead of this person can think that it's a scene from a movie, or it's a simulation, or this might be a photograph from different setting. So a trained psychologist trained all of the participants. We wanted the psychologist to manipulate the patient. So in high-risk patients, the feeling that they experience were higher and elevated compared to the low-risk group. Of course, there are activations in many areas, and we see fusiform here. And in medial prefrontal cortex, we couldn't see the activation because our amygdala is not activated much. Of course, there's even if you do a stimulation, amygdala is not very active. The left part seems more active, but it's not very much significantly active. So in the correlation that we expected, what would we find? We saw that there isn't, especially in the area under the curve, we didn't find a correlation. And what is interesting is that we couldn't find any correlation in between. Regarding HPA axis, there are a lot of data. If you exclude bipolar depression and psychotic depression, most of the research think that they start to produce data regarding that in high-risk group. This might be the case, so we know that the data that we know very well may not be valid all the time. There were some structural changes, however, there wasn't any positive and negative correlation. Regarding emotional regulation problems, we see that HPA accent does not have a correlation. These are linear correlations, actually. While we conducted this study, Davidson groups published another study, and then we were more helpful to take it to another one step forward. These are the resting state analysis are conducted, and in resting state analysis where the patients as they took cortisols from when the patients are from 4.5 years of age, and it is said that this could be related to activation. However, this activation here is present in only female children if there's a childhood trauma of the patient. This is the data. So the childhood trauma here is was very low, only present in 4 or 5 patients. And how, we couldn't think of 4.5 years of age, we took their cortisols and when they were 18 years of age. So we are thinking of whether there could be another window, whether the cortisol might not be as determining as we expect, or could only be determining in only certain ages. And our result is that there was the adrenal insufficiency, contrary to what we believed. And in temporoparental and fusiform areas are maybe the higher cortical thinning or the volume decreasing areas. In hippocampus, we found a very small region, but this region is not in the neuronal cortex, in where the CA4 and dendritic curves is connected. So it's a transfer area. Of course, we started off, expecting a lot, but everything you start with trying hypothesis may not end or turn out if you wish. This is something we learned, maybe one of the most important things we know, and except for that, I have presented everything regarding this, and thank you very much for your kind attention.